PGs are already joining.
Yeah.
Yeah.
The KSOG secretary is there. KSOG secretary.
So Sonia, I don't know. I'll just call her in case.
Okay.
How should it go?
We will have
Shobha,
the
Shobha, do
invocation
it as a
song,
KSOGA.
madam, to begin with.
Okay. Okay. As Aarti can start actually, not a problem.
Yes, ma'am.
She's the master of ceremony. She can start, not a problem. And Dr. Durgadas can give his message, and you can also say something. Then we can go ahead. As Vijay has planned, he has planned the flow. We can go accordingly. Not a problem.
Sure, madam. We'll go like that only.
Yeah, we'll go according to your flow.
Sure, madam. Sure.
Yeah.
Good evening, one and all. I welcome you all to this beautiful webinar on perineal injuries. We would like to start the program by an invocation by myself. I, Dr. Aarti Sridhar, I am the Secretary for Urogynaecologist Committee, KSOGA. So we would like to start any program seeking the blessings of Lord Ganesha, and I would like to give a small song on Lord Ganesha. Gajananayutam Ganeshwaram Gajananayutam Ganeshwaram Bhajami Satatam Sureshwaram Shri Gajananayutam Ganeshwaram Achetra Pujita Vigneshwaram
ಕರ್ನಾಟಕ ಕೊಡೋ ಸಾಹಿತ್ಯ ಅಕಾಡೆಮಿ ಇದು ಸರ್ಕಾರ ಹತ್ರ ಇದೆ ನಂಗೆ.
Vigneshwaram Ganade Sannuta Padapatmakaram Kunjara Banjana Chaturataram Kunjara Banjana Chaturataram Guru Guhagrajam Pranavakaram Kunjara Banjana Chaturataram Guru Guhagrajam Pranavakaram Gajananayutam Ganeshwaram. Thank you. So we'll go ahead with
Aarti, one request is our introductions and other things should be as brief as possible. Otherwise, even if you don't introduce, everyone knows us. So we want to listen to her, and even we should go with whatever your plan, but be brief on that, Vijay Kumar.
Sure, sir. Sure.
So we would like to start the webinar. I would like to introduce Dr. Vijay Kumar, who is the chairperson of Urogynaecologist Committee, KSOGA. And over to you, Vijay sir, for further proceedings of the webinar.
Yeah. So good evening to all. This evening is very special for us, and it's an important occasion for the Karnataka Society of Obstetrics and Gynecology. We have the distinguished speaker, Professor Ranee Thakar, to deliver the lecture on the perineal injuries during childbirth. As we all know that dystocia is a very unique thing which is seen in the Homo sapiens. The various scientific reasons for dystocia is known. Apart from dystocia, even the perineal injury has become inevitable. As you can see in this slide, during the days of Soratus, the perineal care has started as long back as the days of Soratus, wherein the woman used to deliver while sitting or standing. There is a shift in the position of the delivery from sitting or standing to the supine position. This could be an important reason why the perineal injuries have become an inevitable component during the childbirth. So I would like to introduce the chairpersons for this evening. The first and foremost, Dr. Durgadas Asranna sir, who is the president of the KSOGA. Sir is also a member of IMS.
Sir,
Yeah. So the next chairperson is Dr. Shobha N. Gudi, Madam, who is the Secretary General for KSOGA, and Madam has got various distinguished
Yeah, I think it is okay, Vijay. We'll
awards.
introduce the guest. We'll
Yes,
introduce
madam.
the
Yes,
guest.
madam. Next chairperson, our Bellat sir, who is an important person for this evening. Because of his effort, we could.
No, you
Madam.
go ahead
Next
with her.
chairperson is Kavita Banwal, madam, who is the chairperson of the Foxy Urogynec Committee. I welcome you all, and I request Dr. Durgadas Asarana sir to give welcome speech, followed by Dr. Sushila Shobha Gudi madam will be introducing the speaker.
Good evening, everybody. Warm greetings to KSOGA family. Today is a special day that RCOG President Dr. Ranee Thakar has taken her time from her busy schedule to join us to enlighten us about the topic which is very, very close to her heart. She has done extensive work joining hands with Dr. Abdul Sultan on perineal injuries. These two are the real masters in this subject, so much so that their degree of perineal injury has been named as Sultan's classification of perineal tear. The book, which is written by both of them, is almost considered as a Bible for the perineal injuries. Coming to Dr. Ranee Thakar's personal CV, she is from Belgaum, our own Karnataka, Namma Mane Maglu. We all should be very proud about her. Beyond that, she is such a simple consultant. I have met her personally in London. You may not believe so simple she is. We cannot believe today she is the president of RCOG. With this simplicity of her, she is her greatness as to take time and join us in today's evening. With these few words, thank you, madam, for joining. Thank you once again. The stage is yours.
I request
Thank you so much.
Shobha Gudi madam to say a few words about Ranee Thakar madam.
Can I have the...
Yes, madam.
Yeah. Can I have the CV, please?
Arun, can you put the CV of ma'am?
Yeah, I got it. Yeah, I got it. So I think
Arun is sharing that.
Ma'am, you're able to see? Shobha ma'am?
So
Yes, it's
okay.
visible.
So why your network? So your network is not good. You're getting intermittently cut, Shobha.
Heard now. I'm audible now. Yeah.
Yeah.
And move to the better place. Is it better now to introduce Professor Ranee Thakar?
Now you're.
It's an absolute delight, actually. Because we feel, we have heard her before, and we know her, and all the qualities that Dr. Durgadas told. Actually, we are familiar with this persona, but then when she comes as a guest, I think we feel very privileged, and we the sentiment of Atiti Devo Bhava, that becomes very strong in our minds when we welcome Professor Ranee Thakar. Of course, everyone knows that she's the president of RCOG, a very prestigious position. And not just being president, she's doing extremely valuable work and she always has in her programs the welfare of all countries, not just the developed world, but also the developing world. She's a consultant OB gynae, especially specialized in urogynecology at Croydon University Hospital since December 22. Honorary academic. Just a minute, yeah. Sorry, that was my son giving me prasad. honorary academic position at St. George's University of London and University of Liverpool. When there is a list of awards, multiple awards, undoubtedly making India very proud because she is from here, as Dr. Bellad and Dr. Durgadas have already mentioned. She has won the President's Award for Outstanding Leadership and Distinguished Service Award, which is International Urogynae Association Award, as recently as 2022. She is a global health leader as well and has led essential gynecology skills program in Bangladesh, making abortion safe program in 5 sub-Saharan countries during her tenure as RCOG Senior Vice President for Global Health. And that is why I said that she has avidly worked for the underprivileged and has, has close to her heart the welfare of women from underprivileged communities. Advocate for racial equity, delivered e-learning on tackling racism, toolkit on differential attachment and a coaching program for RCOG champions, extensive academic contributions, over 200 publications. I think we have read lot of her work. We still look forward to reading more. Regional leader, leads the Perinatal Pelvic Health Project and Urogynec Network for Southwest London, fostering multidisciplinary collaboration, which is the way to go. Involving more disciplines brings out the best for the patient. International recognition is, of course, very high for her, and we are proud to, I think, the first mentioned is India. Honorary fellowship from medical colleges in India, Ireland, Bangladesh, Australia, New Zealand, and Japan. And we must thank her for keeping India first here. And we are very proud of you, Professor Ranee Thakar, and we are very grateful that you are here amongst us today. Welcome to KSOGA, and the floor is all yours.
Thank you. Thank you for those very kind words. I have to say to you that I never ever forget my roots. And I often say that everything that I do is based on my roots, which are from India. My professors who taught me so much. Some of you may not know this, but I used to be, I was a classmate of Bellad, and we shared the same dissection table for 1.5 years. And then we were classmates for a long time and have remained very good friends, which is quite amazing, actually. So I'm really grateful for the roots which I would say started from my education. My values come from India, and the way I was brought up as a child really is the way that I have led my life, and hopefully has been my North Star. What I look at all the time is, how do I keep India proud? How do I not bring shame to my country? Is something that I'm really very, very conscious of. So I've been asked to speak about perineal injuries during childbirth, a subject really close to my heart. And I was thinking about this, Bella, earlier on. When we did our dissection, we never really bothered much about dissection of the perineum. We were more interested in the brain and biceps and all of these things. But I don't remember us actually dissecting the perineum, and really, for me, that remains one of the big problems with education. If we don't understand the anatomy, we don't understand the physiology, and therefore we cannot treat our patients. So I hope that's going to be one of the messages. But really, pelvic floor disorders after childbirth can have devastating consequences on women's quality of life, often ignored. And it's not surprising that, given the remarkable changes that occur to the pelvic floor during vaginal birth, that this dysfunction takes place. If you want to quantify it, you can say that about 25% of women will suffer some kind of trauma or pelvic floor dysfunction after childbirth. But what we also don't count is the women who don't have surgery. So 20% of women will have surgery for urogynecological conditions. But there are other conditions such as overactive bladder, such as prolapse that doesn't have surgery, such as interstitial cystitis, so many other things that are not counted. And urogynecology has not been given the importance that it should. But it all stems from pelvic floor dysfunction, which stems from childbirth, which affects a woman's quality of life. So over the next 30 minutes or so, I'm going to discuss what is the pelvic floor? What do we understand about this? And the next important thing is what makes childbirth in humans so difficult? Vijay talked a little bit about this. I'll elaborate further. And then what is the mechanism of pelvic floor injury during childbirth? Why does it occur? And what are therefore the consequences of that? But if we want to prevent it, then we need to look at women who are at risk of pelvic floor injury, because you cannot apply the same preventative strategies to everyone. We need to identify those at increased risk and modify the way we look after them. And then how do we prevent it and how do we address training? Because training is really, really important. So what is the pelvic floor? Well, this is the pelvic floor. As you can see, it's bound anteriorly by the pubic symphysis. It's got the ischial tuberosities on either side. I'm just going to try and bring up my laser printer. And the coccyx, it can broadly be divided into the anterior urogenital triangle and the posterior anal triangle. But look at this muscle, the levator ani muscle, which occupies the outlet of the pelvis. And it really is a muscle that has caused so much confusion over years. Because if you look at it, if you look at the muscles, they're sort of going from all directions, and really is a complex structure which is made up of ligaments, muscles, fascia, and all of this is arranged in the most complex way and really support the pelvic organs, and really has remained a mystery for anatomists, as quoted by R.L. Dickinson, who said that there is no considerable muscle in the body, the form and function of which is more difficult to understand than those of the levator ani, and about which such nebulous impressions prevail. So really something that we haven't thought about or even think about the importance of this. It is a really complex muscle with a nerve supply, with connective tissue, and as you can see, keeps our pelvic organs in place, and therefore we are continent. But now let's try and think about what makes childbirth in humans so very complex. Well, it's the way we have evolved from being on 4 feet to become a bipedalic. This whole lineage, human lineage, has evolved over 5 to 7 million years. And really what has happened with that is major remodeling of the pelvis, the muscles, the bone, because from being on all 4 to standing up means that the stresses on the pelvic floor are different. And here you will see that over the 5 to 7 years, the pelvis has changed from this to becoming like this. But in addition to that, over the last 2 million years, there has been a change to the brain, the size of the brain of Homo sapiens. And as the brain increased in size, the fetal head increased and the body increased. And what that then caused is an obstetric dilemma. So you can see previously in this era, that was the head of the cranium, and that is the pelvis outlet. And if that baby is to come out, it will just fall out. Now, over evaluation, the fetal brain has evolved, which actually is a misfit in the pelvis. And that is one of the reasons. The other thing, if I take you back to this picture over here, when this gorilla, for example, gives birth, which is what happens in gorillas, as Vijay said earlier, we have evolved to giving birth on the back. And therefore, that makes us more prone to injury. Whereas when you give birth on all 4, the gorilla or the monkeys, they actually just take the fetus and deliver it out of the vaginal passage themselves. So that makes it much, much easier. Now let's try and think about what would happen to the pelvic floor as that fetus, which has a disproportion, that fetal head, it's making its way through the birth canal. And as it is doing that, it's twisting, it's turning, stretching the muscles. And what therefore happens as that fetus comes out through that narrow hiatus, that fetal head, those shoulders, that big body, it stretches the urogenital hiatus. And this is what happens. That's the narrow vagina over there, and that stretches as the fetal head is coming out. So what therefore happens is that there is pudendal neuropathy, so nerve injury that is related to childbirth is known as pudendal neuropathy, and there can be direct mechanical trauma to that muscle, fascia, and the supporting ligaments that I mentioned earlier. So now let's look at what happens to the levator ani during childbirth. And this is a very beautiful diagram from Professor Delancey, which is hand-drawn. That's the fetal head coming out in the second stage. You can see anal dilatation is taken up. We don't actually think about what is happening underneath this, do we? Well, this is what happens underneath this. There is stretching of all these muscles, and the most medial fibers are more likely to stretch. But it's not just that muscle that is stretching as that fetal head is coming out. There is this nerve, the pudendal nerve. When we say pudendal neuropathy or pudendal injury during childbirth, or that there's nerve injury, it doesn't mean that the nerve is cut. It means it is stretched. And it stretches because it traverses in the Alcock's canal, which is stretched. And therefore, as the fetal head is coming out, that stretches not only the muscle, but the nerve as well. It usually recovers, but in some instances, it may not. For example, after forceps delivery, after very prolonged second stage. But that really is the mechanism of injury. Now, it's really difficult to learn about these injuries. So they have used computerized models. And if you look at this computerized model, this blue sphere is the fetal head, that is the hiatus over there. And now try and imagine that fetal head coming out through that narrow genital hiatus. And what that leads to, as has been seen in biomechanical studies, is the most medial fibers over here stretch. Now try and imagine a muscle that is stretched. So it's like a rubber band, and it can stretch to a certain extent, and beyond that, if it needs to stretch, it actually breaks. And that's exactly what happens. It breaks. And that is seen over here. You can see the fetal head coming out. This green one is actually more tension on the muscle than the red over here. And the highest stresses are put in the pubovisceral and the puborectal part. So those fibers of the levator ani that are inserted into the pubic bone. And try and imagine this levator ani elongates 2.5 times from its initial length during childbirth. So what is the consequence of that? Well, one of the things that happens is enlargement of the urogenital hiatus and the levator hiatus. And this is, if you look at this over here, this is normal and this is abnormal. You can see that there is a widening of the genital hiatus over here. And that when that happens, it means that there is enlargement of the urogenital hiatus. There are ways on ultrasound as well that it can be diagnosed, but you can actually just look at the perineum and you can actually identify that there is detachment of the levator hiatus. So the reason for injury during childbirth to the levator muscle is that the levator hiatus can increase, but there can also detachment can take place over here. And if you just look at the perineum with prolapse, because it's one of the issues that predisposes to prolapse, you will often find that asymmetry. So I urge you to go and have a look at the next person that you see with injury to who has got prolapse, and you will be able to make these really wonderful observations. This is the MRI scan on the same patient. That's the urethra, vagina, and the anal canal. You will see the levator ani muscle that is nicely attached, and here you will see that it is detached. So we were curious to really know the rate of this injury during childbirth. And we did a meta-analysis, and we found that 13 to 36% of women after vaginal birth have this kind of injury. And this is a beautiful image of a transperineal ultrasound showing you bilateral detachment over here. It's almost like that whole muscle falls. And what therefore happens, that it doubles the risk of significant anterior compartment prolapse, that is a cystocele or anterior vaginal wall prolapse, or middle compartment prolapse. And we also know that these women are more likely to have increased risk of recurrence after prolapse surgery. So we also did a prospective study. We did scans antenatally, and we did it immediately postnatally. And we found that after vaginal birth, about 21% of women sustained this kind of injury. You can see over here, you can use your ultrasound machine that you all have, your Voluson machine, and actually look at the pelvic floor. So I would urge you to start using it, also looking at the pelvic floor besides the fetus. So the next thing we wanted to ask is when does this occur? Does it occur during the whole process when that fetus is coming out, or does it occur at the time of delivery, as that fetal head, as that body is coming out through the genital hiatus? So we did scans in the first stage of labor. We did them in the second stage. You can see the fetal head beautifully over here, and the levator ani muscle. You can see it is stretching, and you can see in the third stage, there is detachment over here. So we therefore concluded that this injury takes place at the time of birth. So it's intrapartum. So whatever interventions we want to do, we need to be thinking about interventions that we can do at the time of vaginal birth, as that fetus is coming out through the levator hiatus. So I've told you about the mechanism of injury, how nerve injury occurs, how levator injury occurs. Now let's see what is the consequence of that. And one of them is pelvic organ prolapse. Now you'll see here that it's a levator ani muscle. It keeps the bladder, vagina, uterus, and the rectum all in place. Now, when it opens up, so when there's distension or when there is detachment, those pressures are actually not equal on both sides of the vagina. So you can see over here, this muscle actually keeps the organs in there, and the pressure on the anterior vaginal wall and the posterior wall is equal. However, when injury takes place, this becomes unequal, and therefore these women are more likely to deliver anterior vaginal wall prolapse and uterine descent. So that's a very simple explanation of why levator injury can lead to prolapse. So the next thing is, what about urinary incontinence? What is the mechanism over there? One of it is fascial damage, and the other reason is mechanical damage to the levator ani muscle, and then there can also be nerve damage. But if you look here, you will see the urethra sitting so beautifully on the vagina over here. All the organs are in place. Now, when there is detachment, when there is fascial damage, you can see this urethra actually then just drops down. So when there's increased abdominal pressure in a normally continent woman, that urethra gets compressed. Now, if you have detachment like this, when there's increased intra-abdominal pressure, instead of closing, the urethra then just opens, and that leads to stress incontinence. We have actually shown this by doing bladder scans antenatally and postnatally as well, up to 4 years after birth. And we found that after vaginal birth, whichever type of vaginal birth, there was increase in bladder and bladder neck mobility and urethral mobility, but it was more likely to occur in levator ani injury. And then we correlated that to stress incontinence, and there was a correlation as well. So you can see that the dysfunctions are due to causations which are multifactorial. Now, inner incontinence is slightly different, because here it is due to mechanical damage of the anal sphincter. But in addition to that, it's that neurological damage that occurs due to the pudendal nerve. So anal incontinence can occur due to damage to the anal sphincter, but it can also be due to neurological damage to the pudendal nerve. Now, why is this injury important? Well, it's the most common cause for anal incontinence in women, which has to be the worst symptom that can be inflicted on a woman. It's more likely to occur in women who give birth for the first time, so primips, 3.6 times higher than a multip, and it occurs in about 3% of vaginal births. But it's really important that when we are trying to measure the OAC rates in your unit, that you use the denominator of vaginal births, not all births. So if you just use even your cesarean section rates, your rate will be very low, and it's really not realistic. Now, Vijay earlier mentioned Abdul Sultan's name. He came up with a classification for anal sphincter injury, which is something you should all be using, because we all need to be speaking the same languages. We need to be comparing data. Only then are we going to improve care of women with pelvic floor injuries. So as you can see over here, Abdul Sultan has classified anal sphincter injury into 3A, which is less than 50% of the anal sphincter, 3B, which is more than 50%, 3C, when it involves the external anal sphincter and the internal anal sphincter, and a 4th-degree tear involves external and internal. But it's not only because that we need to be speaking the same language that we need to do the classification, but we also know from a study that we did that as the stage of tears goes up, so from 3A to 4th-degree tear, the symptoms get worse. So it's a good way of also counseling your patients to say, if you have a 4th-degree tear, you're more likely to get anal sphincter. Women are asking us these questions, and we have to know these figures to be able to tell them. But the other thing we need to be aware of, and something we all shy away from, is sexual dysfunction, which is very common after childbirth. And again, the causation is multifactorial. It can be due to psychological causes. We know about postnatal blues. They can also have PTSD, post-traumatic stress disorder. There can be depression, just simple fatigue. Breastfeeding itself leads to decrease in estrogen levels, causing superficial dyspareunia. Incontinence, we know, has an effect on sexual function. Anxiety, the whole change in environment. You go from being a carefree woman to actually, having somebody who's dependent on you. Everything around you changes. There can be trauma. So, the scar tissue from episiotomy or tears, the whole body image changes after childbirth. And there are hormonal changes that also occur. And it is no wonder that women who give birth have sexual dysfunction. And it's an area that I'm really interested in, because I do feel that it can have long-term consequences on a woman's quality of life and also relationships. So the consequences of pelvic floor trauma are urinary incontinence, anal incontinence, prolapse, and sexual dysfunction, as I have described. So the next thing you're going to ask me, but how common is it? Well, remember that these symptoms may not manifest immediately after childbirth. They may manifest later on in life. So short-term studies are important, but really important ones are the long-term. And why do you get the symptoms in the long term? Well, it's the effect of menopause, the lack of estrogen, your collagen tissue changes in quantity and in quality as well. And you can see in this study, which is a longitudinal study over 26 years, that the rate of urinary and anal incontinence in women increased. There was one group where there was less risk of urinary and fecal incontinence, and those women were those who had exclusive cesarean section. It is not that they did not have, they had less risk. So even if you have a cesarean section, not entirely protective of pelvic floor dysfunction, and something that we really need to remember when we are talking to our patients. In this study, they found that forceps were associated with a higher rate of fecal incontinence, and one of the risk factors was BMI for all pelvic floor dysfunctions. So BMI is a big issue. We know that we have a population that has a epidemic of obesity. And when we think about pelvic floor dysfunction, we also need to take into consideration one of the factors is weight or increased BMI. What about urinary incontinence? Well, again, as I showed you in that slide over here, the rate of urinary incontinence is higher after vaginal birth. It goes up with time, but there's no difference between emergency and cesarean section. The prevalence of stress urinary incontinence, urge incontinence, and mixed incontinence higher and most severe in women who gave birth after vaginal delivery. But we really need to measure these. And what this study found is that 8 cesarean sections would be needed to prevent 1 case of urinary incontinence. So why a woman wants to have a cesarean section is a really important question. What about anal incontinence? Again, you can see with vaginal birth, it is higher compared to a cesarean section, but you would need to do 26 cesarean sections to prevent 1 case of fecal incontinence. And again, no difference between emergency and cesarean section. As you can see, almost 50% of women here develop some kind of anal incontinence after childbirth. So what about prolapse? Well, we did a prospective study and looked at the stage of prolapse and also symptoms, and found that 5 years after childbirth, the stage of prolapse worsened after vaginal delivery, but it did not worsen after cesarean section. But that was on examination. There was no impact on the symptoms. So we need to ask ourselves, what occurs first? Is it objective assessment or is it subjective assessment? And clearly, it seems to be that the prolapse can occur first, but it may not be symptomatic. And we see this in clinical practice as well. Well, what happens in the long term? Again, this is a very beautiful study of women who gave birth vaginally and by cesarean section. They were compared. And you can see over here that the symptoms of prolapse were higher after vaginal birth compared to after cesarean section. And you would have to do 12 cesarean sections to prevent 1 case of pelvic organ prolapse. Again, no difference between emergency and elective C-section. So doing an emergency C-section definitely does not cause risk to the pelvic floor compared to elective C-section. So that's something we need to remember. But see over here, the symptomatic pelvic organ prolapse increased 3% for each unit increase in the BMI, and by 3% for 100 grams increase in the infant fetal weight. There's something about the mode of birth and the risk of birth as well. And again, in this slide, I don't know how well you can see it, but this is essentially looking at stress incontinence, overactive bladder, anal incontinence, and pelvic organ prolapse. Highest with instrumental birth, second with normal birth, and third with cesarean section. So there is clear evidence, but we also know that there are risk factors. And if you look at risk factors over a period of time, the risk factors for urinary incontinence, fecal incontinence, and prolapse are actually different. There are 2 risk factors that are common: age and obesity. As I told you, as you grow older, the symptoms are likely to get high, but obesity, and that is something we can do to prevent pelvic floor dysfunction. The other things for urinary incontinence don't necessarily sit with with fecal incontinence and also prolapse. But the common ones, again, are vaginal birth and parity. So the more children you have, obviously, the more likely to have pelvic floor dysfunction. But then the question is, why is it that everyone does not develop pelvic floor dysfunction? Well, when we are born, some of us are born with predisposing factors. Some of us are more likely to have it. Our collagen tissue may actually predispose us to having it. So if you take somebody over an 80-year period, this is what the symptom threshold should be. So if you are more likely to have the predisposing factors, your risk goes up. And then something happens in life, such as giving birth, for example. which then increases your risk. And then you have other intervening factors such as the menopause and all of that. And that therefore really increases your symptom or your risk of getting symptoms. Now, bearing in mind that the long-term effects are visualized as we get older with the pelvic floor dysfunction, what you've really got to remember is, what do we do about these women? We know that most postnatal services finish by about 6 to 12 months. And we know that many of the longer term and often chronic complications are really from labor and childbirth that are less visible and really completely ignored. And as I said earlier, and I've demonstrated to you in the studies, there are many conditions such as pelvic floor dysfunction, depression, that become manifest later on in life. And these can have a long-term consequences. So what we need to be looking at is how do we continue to provide postnatal care and improve it. Even where I work in the UK, the most neglected area is postpartum services. It really stops after 6 weeks, but the women do not have the symptoms then to even complain to you. Some of them may have very severe cases, but then they are left to their own means. And very often, they do not even know why they're getting these symptoms. They think it's part of aging. They think it's supposed to happen. They're embarrassed. They continue to ignore it. So now you're going to say, Ranee, you've told us all these things about vaginal birth. We are all going to have advise our women to have cesarean section. Well, I think it's really important to get that balance right. And the reason for this is that cesarean section is not without risks. So when we counsel women about the kind of mode of birth that they want to have, they hear Ranee Thakar giving a lecture, so they say, oh God, I don't really want to have a vaginal birth, I want to have cesarean section. But then we need to tell them about the immediate risks that can occur, the delayed risks, and the risks for future pregnancy. We never discuss with them the risks of stillbirth, the risks of abnormal placentation. Placenta accreta is becoming a huge issue, scar rupture, so on and so forth. There are so many things. So our counseling is really important. And we know that this doesn't happen well, because this was a study where they did interviews of women, and many of them said that there is really very poor information that is given during the consent process. There's superficial discussion in the antenatal period. That is the time women need to be making a decision. I'm not saying don't have a cesarean section, but they need to understand why they're having a cesarean section. And there's also incomplete and sparse disclosure prior to making a decision, and women are really unaware of the risks. And more importantly, they are fearful of the services that they receive, and they are fearful that a cesarean section may be denied of them. So the next question is, what do we do to prevent this injury? Well, the thing that we need to know, as I said in the beginning, is who is at risk. So if we consider the levator injury, women who have forceps, those who have anal sphincter injury and prolonged second stage are more likely to risk. So we looked at this further and we did a systematic review. And then we looked at the factors that we could modify. For example, forceps birth and vacuum. Instrumental birth was one of the major risk factors. So can we think about swapping forceps for a vacuum? And there are other non-modifiable risk factors. So you can never say that you cannot have obstetric anal sphincter injury. You cannot have it 0%. You can prevent it. But those are not modifiable risk factors, and also maternal age. You can't do much about women growing older and giving birth. And we're all seeing more elderly primates. What about anal sphincter injury? Again, the risk factors are similar: forceps, vacuum, occipito-posterior, prolonged second stage. The problem with prolonged second stage is that the interventions that you have to reduce the second stage, forceps and vacuum, for example, are the risk factors. So is it the reason why the second stage is prolonged that is the reason for the OAC, or is it the instrument? So we need to be thinking about these reasons. And obviously, there are other non-modifiable risk factors such as nulliparity, maternal age, a big fetus. So you could argue if you have good diabetic control, for example, fetus may not be big, maternal age, and shoulder dystocia. So what can be done? Well, in the antenatal period, women can be advised to do perineal massage right from the 34 weeks onwards. It has been shown to reduce anal sphincter injury, reduce the rate of episiotomies, and also reduce the risk of need for suturing and a higher intact perineum rate. What else can be done? Well, warm compresses can be used at the time of birth in the second stage. That has been shown to reduce OAC by 66%. Applying manual perineal protection reduces the risk of OAC. You see, in the Western world, in the 80s, they had moved away from supporting the perineum. This is not something that I learned in India or I had seen, but that is what happened. I think that was one of the contributory factors for raised OAC rates in this country. Use of episiotomy, but selective use of episiotomy. If you use episiotomy routinely, it increases the risk of OAC. But if you selectively use it, and I always say obstetrics is an art. So we mustn't forget it's not black and white. You need to observe that perineum, see if it is distending, and if it is a perineum that's not distending, then you do an episiotomy and avoid forceps when possible. And there are different innovations. For example, the odon that's being looked at. This could become the assisted birth of the future. We still don't know its effects on the pelvic floor because it has not been studied. But I'd like to end by really telling you a little bit about the OAC Care Bundle, which was a quality improvement program that I led in RCOG, along with the Royal College of Midwives. And when our rates went up to about 5%, and I think this is very much to do with non-support of the perineum, we came up with 4 elements of a care bundle. So what is a care bundle? A care bundle is a bundle where you put together elements, and when they are applied together, it reduces the rate of whatever you're looking at. So we considered antenatal information for women because women told us that they are never informed about perineal trauma. We included manual perineal protection, episiotomy at 60 degrees if indicated, and also a per-rectal examination after vaginal birth because diagnosis is really important. And what we did is we chose 2 champions. We have midwives who assist women to give birth and a champion doctor. And they went and taught in their units these different techniques. And then we found that in those units, there was a 20% reduction in OAC rates when they applied the perineal trauma. And this was mainly after the spontaneous vaginal birth. There was no effect on cesarean section or on episiotomy. And we have lots of different publications on this. If you're interested, you can read them. We looked at what women's opinion was on this. We looked at what clinicians' experience was. And we have also done a long-term follow-up. What about India? Well, in India, obviously, I agree that there are lots of really important things, but we also need to think about women's pelvic floor because it can affect women's quality of life. And this was a study that was done in a place near Pune, Vadnar village in Maharashtra. And they surveyed 11 women aged between 18 and 65. And 40% of them said they had urinary incontinence. It said they had pelvic floor dysfunction with urinary incontinence in 32%. They were aware of pelvic floor dysfunction over 60%, which I'm quite surprised at that rate, but only 35% knew about medical treatments. None were aware of physiotherapy. And I think what we need in India is, in addition to all the other maternal improvements programs that are there, is also a pelvic floor awareness included alongside all the other important things that we do. What about the UK? Well, we have a similar problem over here. We have 3 in 5 experience symptoms of poor pelvic health. And there is a lack of awareness and education. So this is a story everywhere in the world, which is one of the reasons why I remain so passionate about it. And when we asked women why they lacked awareness and education, about 1 in 10 did not know what the pelvic floor was. 1 in 4 had never done their pelvic floor muscle exercises, and 1 in 3 didn't really feel confident. And the sad thing was that about 69% had never spoken to anyone in the NHS about their pelvic floor, bearing in mind that they don't have to pay a single penny to come and do this. So there is a shame, there's a stigma attached to this. One way perhaps of helping women would be to develop clinics, and we have a specialized clinic called the Perineal Clinic. We can call it, different people call it different things. And in this clinic, we focus on women who have pelvic floor dysfunction in the antenatal period up to about 16 weeks, and also antenatal women and postnatal women up to 16 weeks who have pelvic floor injuries. And it also is a good opportunity for us to review women who have female genital mutilation, which is becoming quite common in this country because of immigration, and also OAC. It's a multidisciplinary clinic, which I do along with a midwife. And we may need access, we may need help from physiotherapists and our colorectal surgeons and psychosexual counselors. It's good to develop these clinics, make them well known so that women are aware that there is a service for them. Prenatal education is really important. It's becoming part of everything that we do, and this can be included. And when we do this, we need to talk to women about the potential risks of operative deliveries, educate them about pelvic floor related changes, screen for pelvic floor dysfunction in the antenatal period, and educate on those things that are really beneficial, such as pelvic floor muscle training, avoidance of smoking, which is not a big problem in India, avoidance of constipation, and maintaining a normal BMI. So all of this can be part of education. Our TikToks and our social media is becoming really important. So you can have videos. We have an online pelvic floor class, which is delivered by our physiotherapist. And in our own institute, in our area, Southwest London, we have developed an app so that patients can start doing the exercises and really have some consultation on that. And that's increasingly being taken up. What else can happen? Does yoga have a role? Well, this is a study, which was a randomized study, wherein they looked at women who did yoga versus those who did not. And they found that there was a significant improvement in pelvic floor dysfunction. Now, yoga is very fashionable in India, especially in the younger age group. And this again could be part of education. So we need to find really what makes that, what happens within that society when we are trying to make changes. But training is really important. And, there is no age where you can't be trained. I firmly believe that. And we continuously train on in our unit. We have new staff keep coming. So it's important to increase the awareness. I would, for example, advocate for having one perineal trauma workshop every year in your units, your hospitals, or your societies, wherever. We have the Train the Trainers program, which I developed when I was president of the International Urogynaecologist Association. And this essentially focuses on prevention and repair of tears and episiotomy through coordinated training. And what we have is web-based modules, then a hands-on training, and then people send us videos, which we then certify. And I'm really proud that we have Dr. Raja Maheshwari, who many of you know, who was the first certified trainer for Protect. And she perhaps now has trained more people than I have trained. So the last time I spoke to her, she had trained about 2,500 doctors, but I'm sure she's broken that record by now. So she is a very good person for you to actually talk to be able to deliver workshops, etc. in in India, as well as Kameshwari, who works in Fernandez Hospital in Hyderabad. So in conclusion, I hope I've covered the various topics that I said I would cover, starting from what is the pelvic floor to addressing training. But I want to leave with one message. Whenever we are looking at a woman, next time you touch an abdomen, a pregnant abdomen, think also about her perineum. We need to have a holistic approach. And I think this saying by Socrates really holds true. And this, he said, is the reason why the cure of many diseases is unknown to the physicians of Hellas, because they disregard the whole, which ought to be studied also. For part can never be well unless the whole is well. Thank you so much for your kind attention.
Thank you, ma'am. That was a wonderful session. Vijay, sir?
Yeah. Please go ahead.
Yeah.
I am extremely thankful to Professor Ranee Madam for delivering such a beautiful topic. So I just wanted to know, is there the position of the delivering woman, does it matter? And nowadays we have something called birthing underwater. Are these the things which will make any difference in the perineal injuries?
Yeah. So if you look at the randomized study, I'm going to talk about evidence base over here because that's what we need to do. So where you were talking about lying flat on the back is perhaps not the best position to give birth because it defies gravity and everything. But the randomized studies in position is actually very difficult. So if you look at anal sphincter injury, they haven't actually shown a difference, but that is probably because it's very difficult to stay in one position when you're giving birth because it's not exactly the most pleasant experience. And when you give an epidural, for example, then you're stuck in one position unless there is a mobile epidural, which is available in very few units. So there is evidence that if you have birth in the sort of standing up position, you are more likely to get a second degree tear. But there isn't any sort of very good evidence. But I know that there is a tribe in Brazil that give birth by holding on to the rope, and they have a very low rate of perineal trauma. But there's a lot of work that needs to be done in this area.
Thank you, madam.
Wonderful.
Should I say a few words to Vijay?
Wanted to ask questions also. I had a question. You speak, Kavita, then I'll ask a question.
Okay. So, madam, it was an excellent presentation, starting from anatomy, physiology, causes, how can we prevent? And I think cesarean is not the solution of preventing these injuries. So this is very important to know the OSC bundle. That is very important so that we can prevent the injury in most of the women because they are sufferers. And one thing more, I live in Yoga City, Munger. So here many women come and they are taking part and they are doing yoga regularly and they have less chances of this type of injury during childbirth. So many foreigners are also residing in our part. This is Yoga University. We have first type of World Yoga University.
That's very interesting.
Dr. APJ Kalam sir has visited this place 2 times. And always remains filled up with foreigners. So we have this opportunity, and I had also written a book, Yoga and Pregnancy Labor, and that explains that those women who practice yoga during pregnancy, they had very less chances of these perineal injuries, as madam has explained. So thank you so much, madam. We are lucky to have you as speaker. Thank you, madam.
Wonderful. That was
even Sheila madam wants to join.
Hello, Sheila. Do you want to?
Yeah, hello.
Yeah, hello.
Yeah,
Hi,
yes.
Sheila.
Thank you. Yeah, hi. Thank you. And Dr. Ranee, nice to see you again virtually.
Nice to see you.
Yeah. So I think we met in Mumbai RCOG. So still my memories are very fresh. Excellent presentation. I think Dr. Vijay Kumar has really helped all of us by arranging this webinar, and where we had such a important deliberation on OSCs, I think it is very important. So thank you once again for accepting the invitation of KSOGA and enlightening all of us. Okay, thank you.
Yeah. So, Dr. Rani, I had a query. Now, when we look at the changing practices of especially the later part of first stage and the second stage of labor, today the guidelines which have come up, a very strong advocacy for allowing women to labor for longer time will result in a reduction in cesarean section rates. And the WHO labor care guideline, which has come up, it allows women more time in labor, right? So, and earlier, maybe a decade back, the concept was that second stage needs to kind of play itself out, and women need to push at a much later date. But today, even though greater time is being allowed for cervical dilatation in WHO LCG, it says that early pushing in second stage needs to be promoted. So I just wanted to know from you, because I've always wondered about this, the implementation of WHO LCG, will it have an effect on perineal health because of the time factors which are allowed with the head on the levator and eye for so long, and the early pushing? Does it have any impact? I just wanted to know that because we are actively practicing that now.
Yeah. So there are guidelines and there are guidelines. And this is why I say to you, which I said earlier, obstetrics is an art. And we are forgetting, we are making it black and white. Why do we allow the second stage to occur? The second stage actually is distending the perineum. Yeah, and gradual. So one of the reasons for the tears is a very sudden expulsive delivery. So we want slow delivery, slow stretching of those muscles, and therefore, so if you try and sort of pull a rubber band really hard, it will snap immediately. But if you can stretch it longer if you are pulling it for a long period of time. So again, it comes back to what I said: is that injury due to the prolonged second stage, or is it the instrument that actually caused that injury? So second stage of labor is, I'm no expert in it, and I don't think there is any expert in the world, because it is really quite complicated. But I think the thing is to listen to the women. They start pushing when they get the urge to push. Pushing too early is she'll be exhausted. Then she'll end up with forceps delivery or Wantus delivery, higher risk of perineal trauma. So again, it comes back to when she feels, how she pushes. At the time of birth, I didn't have time to actually go through the video of giving birth, but at that time when that fetus is coming out, it's not about pushing. At that time, it's not going to go back. Remember in my medical school where we learned about the power of the uterus. Nothing can stop the power of that uterus. So once the head is on the perineum, it's going to come out. You don't ask them to push them. You ask them to breathe, and that then stretches out. That pushing, it sudden pops out, and that causes the perineal trauma. The other thing to remember is that often the injury occurs due to delivery of the shoulders. And so at that time, you have delivered the head, you are relaxed. But it's the injury occurs during delivery of the shoulder. So it's really also important to continue supporting the perineum at the time of delivery of the shoulders.
Yeah, Ranee, fantastic presentation. As usual, yeah, and just want to share that these days, patience is very less with the people, and that is why we are ending up with the fundal pressure. All these practices are there. Actually, if you wait, there is a what is called as propulsive phase and expulsive phase of second stage. Moment people think that she went into second stage of labor, we must ask her to push. That practice should not be there. And rightly covered well. I just wanted to know, Ranee, do you have any experience with that, perineal protector device that this article has come in American Journal in 2024 September. I just wanted to know because
Epino, the one in the, yeah. So that did not show the studies that, so the companies marketed it a lot. It's a device that is put in the vagina and it's like a balloon that you distend, and it is based on the same thing that I said, or they sell it, that it's stretching your pelvic floor. But the studies that were done, it was done by Peter Ditz from Australia, and he found no difference in perineal tears or even in levator injuries.
Yeah, that's nice. Thank you.
Ma'am, would like to know about the water birth and its consequences on perineal injuries. Any
Yeah, there are two things about water birth, isn't it? There's the giving birth and using it for pain relief. So for pain relief, it is fine. For giving birth, there has just been one study which looked at that, and they didn't find an increased rate. But I know of other centers, because you can't support the perineum at all. So if you go to Scandinavia, where they do the manual perineal protection, that's where it came from. Their water births actually have got like a shelf where a person can, the woman giving birth can sit on, and you're able to support the perineum. But intuitively, you would think that giving birth with no support, although there is really clear evidence, there isn't very, very clear evidence, but we know of some studies that have shown that, and there is one study that was recently published, and that did not show that, but that was not the primary outcome. We need to be very, very careful about what people are measuring.
Ma'am, there are some questions in the chat box. Can we take that? So one is, can pudendal nerve injury be cured?
No. So pudendal nerve injury in the early stages, it will regenerate, and so you can also get pudendal neuropathy with chronic constipation. Yeah, so it's about stretching the pelvic floor. Can it be cured? Unfortunately, in the first few initially few months, it might sort of get better, but it's one of the long-term consequences that can occur.
Thank you. Ma'am. The next question is role of perineal support and Ridgen maneuver.
Yeah, so the one that so when we talk about perineal support, the one that is not just putting your hand on the perineum. The one that we do for the OAC Care Bundle, which you all can get the videos or whatever from the RCOG website, is the Ridgen manual where you put your hand on the perineum. These three fingers sit on the perineum like this. Can you see it? Yeah. These three fingers sit on the perineum. These two fingers are around the vulva. You don't have a gap between this and that. And then with your non-dominant hand, you put your head on the perineum and allowing that slow birth. So this is modified Ridgens. The other Ridgens, the original Ridgens, which has a very low OAC rate, they used to put one finger in the anal canal and all. I don't think that was ever going to become, I don't think it's necessary as well.
Yes, ma'am. The next question is, any direct relationship between the body mass index and urinary incontinence?
Oh, yes, absolutely. So as I said, all of these pelvic floor dysfunctions increase with maternal weight. So when I see my patients with urogynae problems, I encourage them to lose weight, because just by losing weight, they can improve. They don't need surgery. Surgery in them is more complicated, more likely to fail. Obesity is one of the biggest issues that we have right now.
Does obesity affect urge incontinence as well, madam?
Yes, all parts of pelvic floor dysfunction, but more stress incontinence.
Ma'am, one question is, how do we give warm compress?
So warm compress, you take, let me get the tissue. For example, if this is a pad.
raise your hand a little. Ranee, you have to raise your hand. From the...
For example, yeah. For example, if this is a pad, yeah. If this is a
Yeah.
pad, I'm trying to. And what you do is you put it in warm water, slightly warm, not too hot. You then take out the water, and that is applied on the perineum in the second stage. Yeah, and then when it becomes cold, again, take it out, put it in water, take out the water, and then put it back.
So it functions by, how does it function?
It's a very, very good question. So this is, there is a lot of work done in this area, some really strong proponents in Australia. And if you look at the Cochrane review, there's a 50% reduction in OAC rate by using the warm compress. Now, I think it's the support to the perineum that comes when you're putting that warm compress, because I'm not very sure how warm water can actually reduce OAC rate and or cause any change. But whatever it is, look, it reduces OAC rate, so do it.
I think it supports the tissue better.
Muscle
Muscle
relaxes the
relaxation.
muscle.
Correct.
Yeah.
Actually, that's why earlier they used to use for warm compression for the uterine contraction. Actually, it relaxes more than the compression and contraction. So perineal support, muscles also with the warmth, they relax comparatively.
They relax. And also there is one more element. I think it is very soothing for the patient to have, because it has some benefit of analgesia is what I feel. Yeah. So, I mean, it may not be related to perineal injury, but it's useful. It improves the care in labor. Yeah.
Yeah.
And the next question is, how do we know that a woman is collagen deficient? Is it only reproductive or
so one of the things is you do this, the finger will go right behind. Then extensing with that thing, you do this, skin will come. So that's one of the indication, and then you do genetic testing.
Is it common though? Yeah.
It's not so common. No.
We see it very less. But usually many people know about this hyperextensibility. I have seen at least 2 or 3 individuals tell me that, there is so much of more extension than others. Yeah.
They don't necessarily always have. You can have more collagen, or you can have hyperextensibility, but that doesn't mean you have a genetic disorder. It's just the way you're made. So, but you also have Ehlers-Danlos loss syndrome, which
Ehlers-Danlos, yeah.
I've never seen when I trained it. Yeah,
it may be a physiological variation towards the lower side, maybe.
Can I ask, what is the role of now we have aesthetic gynecology and laser therapy? Ranee, what is your view about it for the urinary incontinence?
So the data for urinary incontinence is not yet there. There is some evidence that it helps with lack of estrogens, so menopausal changes in the vagina, genital syndrome of the menopause. So that is what, but for urinary incontinence, still there are studies going on. But it's being flogged quite mercilessly.
Go ahead, madam. Madam. So shall we conclude the session, madam?
Yeah, just one more, Vijay, which Ranee is already, she was speaking, but then I think she didn't want to continue, but then I thought that I will bring it up, because since Sheila has brought up a very contemporary issue, I just wanted to tell Ranee also, that in fact in India there is a lot of hype about cosmetic gynecology, and then it is all.
You've gone.
Ma'am, you're not audible. Shobha ma'am.
I am now, right? Good. Yeah. So it's also called regenerative medicine, which is a very big word and very big phrase, as if really there is a lot of scientific research behind it. But when we start looking at the evidence, we don't find anything. So,
Again, your audio is lost, ma'am. You're not audible, Shobha ma'am.
I don't know. This is a trick. Okay. That's what I'm agreeing with Ranee that a lot of work has to still happen. And I think.
But I think this is where your advocacy comes in, where societies like yours need to be presenting the data, inviting people and questioning people who are, we all have PubMed now. Before if there is something like that, our job is to protect women from having to pay unnecessary amount of money for what may or may not be a good thing for them. So it's patient education. It's about how we talk to women. It's about educating healthcare professionals.
Vijay, can you permit me one last query?
Please, madam. Please, madam.
See, there is a doubt in everyone's mind that when we start talking about perineal injury during natural birthing, will they start asking for more cesarean? How exactly the counseling is structured? Do you have any standard counseling tool for this purpose? Because we always feel anything like that we say, whether they will start getting afraid and ask for more cesarean.
Yeah, so yours is a very valid question. When we did the OAC care bundle, we were told the same thing by the midwives, that if you tell women about, because remember, one component of our care bundle was providing information.
That's what,
to women. Although women afterwards and before also told us that they wanted to know information. It's very different now. Women want to know what is going to happen to them during birth. What are the consequences? So women did tell us about it. But midwives said to us, if you tell them, then they are going to want to have cesarean section, or they are going to, and there will be more episiotomies. But in reality, we did not find that. So we develop a lot of material for education, etc. And if you go to the RCOG website and there's a OAC care bundle, you can just register and we will send you all the material. And within that, we created videos on how to talk to patients, what you need to tell. So it may be a bit different in India, how we talk to our patients.
Yeah, it is different indeed. Yeah.
Thank you.
Thank you so much. Thank you so much. Thank you.
So can we conclude the session?
Thanks, Dr. Bellad, on a 1-to-1. Thank you so much for bringing this to KSOGA. Thank you.
Thank you,
thank all of you.
Thank you very much.
Thank you, Bellad sir. Thank you, Ranee madam. That was a wonderful talk. We are actually privileged this evening to have you. Now the vote of thanks will be given by Dr. Aarti Sridhar.
Yeah. Thank you so much, ma'am. Ranee ma'am, heartfelt gratitude to you for being here with us and sharing your knowledge about such a wonderful way to deliver your comprehensive and engaging presentation. It was really insightful. Thank you so much. And I once again thank all the chairpersons, Dr. Bellat sir, Dr. Shobha ma'am, Dr. Kavita ma'am, Dr. Durgadas sir, Dr. Sheila ma'am, for being here with all of us and sharing your experiences. And I would also like to give a special thanks to Vijay Kumar sir for taking pains in organizing such a wonderful session. And I would also like to thank our President, Durga sir, for giving us this platform to share our knowledge and hear from expert speakers, and not but the least, I would like to thank Mr. Arun, who is behind the scenes, but helping us in making this a successful one. And lastly, I would like to thank all the delegates. Today we have crossed almost 200 people, and it is really a very wonderful gathering.
Very good.
Thank you all for
Very good. Very good.
a wonderful evening and wonderful session by Ranee ma'am.
Wonderful. Congratulations, Vijay.
Thank you, madam. Thank you, madam.
Congratulations. Very nice. Very nice.
Very nice. Wonderful, Ranee. Looking forward for more from you. More. It's so nice to share information. You really come across